Number two, once they gather the information, can they read and understand what that means? Okay? And number three, once they read and understand what that means, do they know how to act? So gather, understand, and act. If they don't know how to gather information, 2 and 3 goes out the window. If they can't read, they don't know what to do. So you can't have one without the other. So they have to be able to gather, they have to be able to understand, and they have to be able to act. So the challenge this represents is, how am I, a small health IT company, going to train everybody to become more health literate? And you really can't. So our approach is that we can do things to overcome these obstacles. So to gather information, can we consolidate information for the patient? Can we focus on key messages, reduce clutter, reduce noise, so that the most important things kind of pop out for them? To help them understand, can we give them information at an appropriate reading level in their language in both written and verbal form? And also give them visual representation, so that if they have a hard time reading that information, that they can look at the pictures to see kind of what that means. And also, why not be able to support larger font sizes for visually impaired and elderly while we're at it as well? There's no reason why we can't do this. And the acting part, recommending specific actions that need to be taken, encouraging dialogue between themselves, their pharmacists, and their healthcare provider, and also making this personalized. So it's not off-the-shelf document for a particular medicine, but it's, why are you taking this medicine? So that's kind of our approach to overcome the health literacy issue. So this is what patients get. Okay, this is called the CMI, or the Consumer Medication Information Sheet. And this is basically CYA for pharmacies. You know what CYA means? Yeah. So I don't understand what a lot of this stuff says. Okay, and my pharmacist friends tell me that 90% of people throw this away, in which case, if they do, what's left? It's the pill bottle. That's all they got. Okay, so why not give them something that's more approachable, understandable, readable, and that's what we try to do here. So this was a grant funded by the NIH. Our approach is to make this as visually enticing as possible, one line per concept, a lot of white spaces. Reading level is targeted as 5th to 8th grade reading level. And one thing about reading level, lower is not always better. Okay, so if somebody says, why can't you do it at 2nd grade reading level, you lose a lot of context when you go too far down. So having a range somewhere between 5th to 8th is pretty much appropriate. Focus on the key messages, which is how to use the medicine safely. There's a feature called the Universal Medication Schedule, which is a recommended 4-time-of-day dosing schedule for patients who self-administer medicines. And we actually represent the number of the times with the different pictures of times a day. So even if you didn't know what that meant, you can kind of look at the picture and kind of figure it out, right? So we use pictograms for dosing. So what is 5 ml? Can we show them with a cup or a syringe? We have actually 5 different font sizes, and we have multi-language support. We can do this in 22 languages now. There's no reason why we can't do this in other languages. And we have a patient portal where patients can access the information. And we also have demonstrations of complex medicines that I'll show you in a second. So the first one is this instruction sheet for a particular medicine. Why am I taking it? How much do I take? And being able to do it in 18-point font size for my elderly Chinese person in traditional Chinese, okay? So the second part of this is medication adherence. So first one is medication error, reducing that. And can we do something that gives them an actionable calendar in their language that they can follow? So here's an example of ones. So at the top are medicines to take every day. The things at the bottom are things to be taken as needed. And you can see that we're using the Universal Medication Schedule 4 times a day, just stacking it on top of each other so that you know what to take in the morning, what to take in the evening, and what at the bedtime. And the right column is for auxiliary instructions around what the medicine is for. And I have a beef with the lack of indications for a lot of these medicines. Patients really need to know what they're taking, and if the provider does not include that, it's just stupid in my opinion. So, and also at the bottom is a QR code that if they do have, and you'll notice that everything we do is on paper. Common denominator is paper, okay? But if they do have a smartphone or tablet device, and they do have a QR code scanner, they can actually get a demonstration of how to use that device no matter where they are. So they can share it with their caregiver, family member, things like that. So once they scan it, this is what they would get. It's a video with audio narration of how to use the device. So when I first started this project, I asked the pharmacist friends, what kind of demonstrations would you want? Okay, and I thought they were going to say glucose meters and meter dose inhalers and stuff like that. Number one request, guess what it was? Rectal suppositories. Okay, so I thought, why the heck rectal suppositories? And they told me that patients were inserting without unwrapping the foil. And they were impacting the kids, and the kids were ending up in the emergency department. So what that tells you is you can't assume anything, okay? So being explicit, having the ability to, comprehensively give them something easy to take with them. Also, 50% of patients forget what you tell them once they walk out the door. So having something written to take with them is, just as important as having an oral translator on the phone as well. So we do this in over 20 languages, and these are the ones that are listed here. So that's the medication tool that is addressing medication techniques, reducing medication errors, and medication adherence as well. So the second thing that I wanted to talk about is I now represent the Lewis Sullivan Institute for Healthcare Innovation, and we are working to form a work group on creating a portable patient medication list that's patient-centered, accessible by the patient caregivers, that can be accessed by the healthcare providers, the pharmacists, and we are looking to put together a work group with people of diverse interests with the focus on the patient. How would the patient use it? How would the caregiver use it? Why would they come back? And being able to enable third-party providers to tap into this medication list to provide services like multi-language instructions or additional resources. So if you are interested in participating, the announcement is going to occur next week. So we were trying to get it done before I came here, but if you are interested, give me a business card and I will send you an email when that comes out. So with that being said, I think I have like 2 minutes. 2 minutes. Okay. Sure.
So you mentioned the portal and the communication with the provider. Have you, hopefully on your work group, you're going to consider putting those lovely people from the electronic medical record companies? Because there's nothing more frustrating from a provider's standpoint than having to log into multiple things when that just doesn't fit their schedule. So I think there's a lot of portals out there that providers can get access to, but it means one more click, leaving the electronic medical record, having internet access, and it's not going to happen in a really busy practice, and we need it to happen.
Yeah. So one of the challenges we had with this particular project is where are we getting this med list from? So we were talking to a lot of EHRs, and the EHR vendors have multiple med lists within their system, and they can't even tell you what the patient's on. So how is the patient supposed to know what they're taking if the EHR vendor who's making the med list doesn't even know what you're supposed to be taking? So, we have this thing called the true medication list, right? And the true list is whatever the patient's taking. So, for me to, when I'm doing intake at the admissions and the patient comes in and I ask them, what are you taking? For them to give me a card and say, would be really nice. Or if I'm discharging them to be able to populate their list. Or if they're coming in to see me as a follow-up, to be able to update it. Or the patients to be able to add their own multivitamins or whatever. This kind of portable, interoperable medication list just it's not out there. And we want it to be something that's nationally driven. We don't really care where it resides. It could reside in multiple places, but it really has to start with the patient. So we want you guys' input into what this should look like.
I have a question, actually. I was wondering for the hard of hearing communities and the deaf communities, are you looking into American Sign Language as a language to offer?
Okay, so we get this question a lot. So for the demos, we have closed caption for hearing impaired. And most people who are hearing impaired can actually read. So you're talking about people who are blind, in which case we don't do Braille.
Hi, James Palmieri from California North State University College of Pharmacy. I'm just wondering, the materials that you're showing here in the slide, are these custom translated but from the prescription?
No, actually, we actually had to do research because when we started with those monographs, and nothing makes you focus than wasting money translating crappy information into another language. So we had to simplify the information in English first. So that took a lot of effort into what kind of information do we want to include. So we don't do drug-drug interaction stuff, which should have been taken care of at the pharmacy, but things like, shake before using, keep in the refrigerator. So we have about 4,000 concept phrases that was translated by a human translator, reviewed by a second agency, which confirmed the accuracy of the first translation. And what we're doing is when you come in and select your language, we're actually swapping libraries of phrases and presenting them in new format. And we support right to left languages, as you see in Arabic. I think we're out of time.
Thank you so much. Thank you, Charles. And do make sure you see him if you're interested in participating in that work group on the portable med list. That's a great example of collaboration and offers to help out. So our third presentation on strategies to improve medication adherence is on transitions of care and comprehensive medication management. And we're pleased to be hearing from Marilyn Stebbins, who's the Vice Chair of Clinical Innovation, UC San Francisco School of Pharmacy.
Well, first of all, I'm the non-academician's academician. So I'd rather tell you a story today than really give you a lot of slides on data. You're going to see some data behind me, but I'd really like to weave this into a med talk instead of a TED talk, because I think that that's the key to this. But I want to be on your group because I've been seeing patients for 25 years doing comprehensive med management as a pharmacist, and this is a huge problem. We have major issues. But what I want to talk about today is sort of the medication management issues during transitions of care. So this conference is talking a lot about adherence. I would say transitions of care is almost as equal a buzzword these days as is adherence. So adherence and transitions of care really are linked, and I'll show you some of these. And where's my change here? So this is actually way too apropos for this last weekend of fires that are going on. And I would tell you that my data, first of all, how many students in here? All of my data has been collected and has been part of student and resident research projects. So I'm going to give you a hodgepodge of data, but I really want to do it to tell a story, and this is the story. The burden we're putting on the back of our patients. In transitions of care, look at this gentleman. I mean, currently, chronic disease is so prevalent, especially in our elderly. We discharge them from the hospital. We give them medication instructions, we give them doctor visits, we give them diagnostic tests, we give them everything. And on top of this, I'm going to show you, we give them phone calls. And all of these things are really breaking the back, but as I always say, it is rather miraculous. Our patients are living in spite of us. It's shocking how wonderful this human body is, because all these bad things that happen to patients, and they still manage to survive. But we must get better. So when I began the world of transitions of care, I had been a primary care pharmacist for 25 years, and I moved back to the university. I'd been contracted to a physician group 90 miles away. I was here in Sacramento, my university was in San Francisco. And I went back and I decided, there is a major problem with our hospitals. And we're not getting patients cared for properly in the outpatient setting because we're discharging people in a very unsafe way. So I started thinking about what I wanted to do in transitions of care as a pharmacist. So first thing I did as an academician is look at the literature. And if you look at the literature, there are several different, or many different systematic reviews that really look at what pharmacists have done in transitions of care. And I'm not going to read this to you, but overarching is that everybody that looks at transitions of care, really, many of them as pharmacists are looking at it as an inpatient process of medication reconciliation, which means getting an accurate medication list. And unfortunately, that takes a lot of effort. You were just speaking to what you try to do at admission, discharge. It's really, really difficult, and it's intensive. So really, when you're doing these types of things, you've got to target in on those people that need you the most. It's much like med synchronization. You've got to get those people that are at the highest risk and work with them. If you look at another systematic review that was recently published in Annals of Internal Medicine, it showed that medication reconciliation alone, getting that quote-unquote accurate med list in the hospital, does not reduce post-discharge hospital utilization. So all the reasons we do it, cost of readmissions, probably doesn't work alone to do that. But when combined with multiple other efforts, inpatient, outpatient, and bridging interventions and community interventions, all of those show stronger evidence of improving post-hospitalization utilization. So again, it's this whole idea that it takes a village, and it also takes interventions at multiple steps, all of them keying in on the patient and what the patient is taking. So I'm just going to walk you through sort of my journey. So I walked into UCSF with this really cool transitions program that I wanted to implement that involved pharmacists, inpatient and outpatient. Went to a meeting and discovered there were 17 different transition of care programs at UC San Francisco, and none of them talked to each other. And if you had congestive heart failure, you could be called by 5 different nurse case managers that had no idea another one was even calling you. So I decided right then and there that my program was going in the trash, and I was going to join forces with another group that was working. And I wanted to identify the medication issues at discharge before I developed an intervention. I think we always, as pharmacists, try to solve things when we aren't even sure what the problem is. So I got together with the nurses who were doing an automated, they were just initiating an automated voice response system for all discharge patients at 48 hours. So I joined them and said, can I put 3 medication questions on your list that will go to the patient? And they said, sure. So we asked them, first of all, if you were discharged medications, did you get them? If you got them, did you start them? And do you have any medication questions or concerns? And we asked this in 9 languages. So people being discharged were being asked in the language that they had. And if you look at this, it's really rather interesting that patients, when we broke it down into what were the real medication-related problems, and this is just a very short snapshot of it, we found that probably 40% of the reasons patients didn't have had questions at discharge or had issues at discharge were systems issues. So if you look at systems issues, they had insurance issues, they couldn't get to the pharmacy, or there was something wrong with that doggone electronic prescription, or somebody forgot to give them their controlled substance prescription. But 60% were clinical issues that were keeping people from taking their medications. And if you look at those, many people have medication questions. They don't understand their prescription directions, and they're not going to take it until they do understand it. Or they have that famous side effect question. And again, it isn't that I'm having one, but I'm afraid of one, or my neighbor had one. And so these are the issues we found in our 48-hour discharge program. And interestingly, this is in year 2. Week by week, 74% response rate. I told them this will never work. People hate those automated phone calls. But guess what? When they were told at discharge that they were going to get this call and not to miss it, and the banner would say UCSF follow-up, and this is your chance to tell us how we did, shockingly, they waited for the call and they knew, and they're answering it. So 74% response rate is huge. So, everything we did involved a survey. So we surveyed patients and asked them, does your doctor or other healthcare provider know all of the medications you take? And we included supplements, over-the-counters, vitamins, and minerals. 86% said yes. My doctor knows everything I'm taking. How many doctors in here?
I don't know if I should raise my hand.
Yeah. Well, our data suggests that that simply is not true. Another study we conducted was comparing our after-visit summary, which is the document that goes home with the patient, post-discharge, that 13-page nightmare that comes out of Epic, that tells them everything in the world, including a med list. And when I was on the circular drive at UCSF surveying 15 discharged patients and asked them if they had a med list, all 15 said no. All 15 had an ABS in their hand. They had no idea that that was a medication list because it isn't. It's an electronic prescribing tool. It is not a patient-centered medication list. So what we did is we took it one step further and said, let's compare this after-visit summary med list with the med list of what the patient's taking, and actually combined with what they're supposed to be taking post-discharge. So we compared these two lists and found 4.5 discrepancies per patient. And this is at a major academic medical center. We are not doing well. Huge numbers were from drugs that were omitted on the discharge list, but really necessary meds, and patients were taking them at home. 44% were meds on the after-visit summary that the patient had had DC and wasn't supposed to be taking. So what does that look like to you? That looks like a drug misadventure waiting to happen, or drug misadventures happening. And that's why I say our patients live in spite of us. But we also went up on our floors and we surveyed patients and asked them if they'd like to come to a visit post-discharge with the pharmacist to go over their medications. And guess what? Patients didn't believe they had a need for this. Oh, my doctor knows my meds, or my pharmacist at Rite Aid and Walgreens, they go over my meds when I get them. However, when we did a very simple, there's no science to this, very simple 7-question survey of these patients, 30 to 50% had some sort of medication question. That they went, oh, you'd cover that? You'd talk to me about that? Well, I just talked to them about that one drug I'm picking up that day. You would talk about this? So again, when we ask the questions, and that's the big key, when we ask the questions, we get the answers. When we don't ask the questions because we don't have time, we don't get the answers. And patients believe that they really don't have medication issues unless it's staring them in the face. So, in one of our studies, we looked at who are the people that when we went up on the floors in our general medicine unit and asked them if they wanted to come to a post-discharge medlist clinic visit to get an accurate, portable, patient-centered medication list, who comes to the visit? And interestingly, we had 300 patients that we looked at and compared between those that came and those that didn't. We looked at everything. We looked at every demographic piece you could look at. And we found that the only statistical significant difference was patients who were non-Caucasian came more often. Patients who had had ED visits or hospitalizations within the last 30 days tended to want to come for a visit. And patients who had a past medical history significant for asthma or cancer. Interestingly, those were the two diseases that came out. We looked at ED visits and hospitalizations within a week, within 60 days and 90 days, and the only one that came out statistically significant was 30 days. So we found this kind of interesting. What was more interesting is what we found out in these medlist clinic visits. And we found that when we were looking at these patients' medications, thank God they weren't adherent, because their meds weren't optimized. So we found that 48% of our patients were on either inappropriate or ineffective medication regimens. And you add to that 18% that had adherence issues, And we're talking about 70% of patients that really were having major potential issues. Not to mention those that were already having adverse drug events or potential drug-drug interactions. So, preliminary data suggests that patients believe providers know all their meds. Patients really don't have a mechanism to self-identify or uncover med issues if we don't ask them. Providers don't access correct information. They think they're getting correct information, but what they're accessing is very often inaccurate. And when asked immediately post-discharge, patients self-identify medication problems, and medication-related problems in transitions of care are not unique. Every institution has them. And if you look at the literature, I think I would tell you, I was just listening to Steve Chen a couple weeks ago down at USC, who's got a major CMMI grant. His appropriateness and effectiveness data looks exactly like mine. 50% of patients are on non-optimized medications. So if medications are the cornerstone of chronic disease management, preliminary data suggests that we're definitely not hitting the mark. We need to optimize meds because they're increasing our risk of medication misadventures. So I'd like to just switch gears for a second and talk about sort of MTM versus comprehensive med management. Medication therapy management grew out of Medicare Part D and the need to have this sort of Medicare patients who are high cost, high disease, high medications looked at. But when you look at MTM from the PBM and plan perspective, they're looking at adherence as a number. But again, as I said, if 50% of our drugs are not optimized, do we want patients taking them? So we need to have a better mechanism for comprehensive med management that gets people on appropriate meds first that are effective, and then we can deal with the adherence. So I would tell you that the first step in any sort of med management is patient engagement and patient activation. Patients must own their med list, and I don't care how they want to own it. I agree with you. Most want paper. They don't want that handy-dandy thing. The ones that are on the most meds are the ones that usually want it on paper. It needs to be accurate, it needs to be portable.